Welcome to the Curtis Universal Ambulance Narrative Writing PowerPoint. The version of narrative writing that you will see here today is not the only version available to EMS providers when we attempt to write a high-quality patient narrative. Please choose a version of narrative writing that best suits your needs and is supplemental to our patient care record. Found a 65-year-old female laying supine in bed at nursing facility. Chief complaint was vomiting. Staff RN states patient vomited twice. Patient vitals and medical history obtained. Patient was secured to cot and transported. Patient monitored without change. Patient care and report were transferred to ED staff. Unit returned to service. Now, unfortunately, this is an all too common narrative in our industry. This is not a good narrative and does not give a good representation of the patient's current condition and everything that we did to help them. ICHARTED is going to be the version of narrative writing that we will talk about today. This stands for our incident response, our chief complaint, history of present illness, our assessment, our treatments, our transport, our reevaluation, and finally the disposition of our patient. We will begin with a simple narrative for emergency transports. Here is a revised example of that narrative. We'll start with the incident response. Unit 356 was dispatched and responded with lights and sirens to a skilled nursing facility for a 65-year-old female that had been vomiting. EMS arrived without delay and found a 65-year-old female alert and oriented to person, place, time, and event in no apparent distress, lying supine in bed. Here is the chief complaint portion of the narrative. When interviewed, the patient is currently without complaint. Facility staff states that the patient had 2 episodes of emesis and are concerned that the patient may be dehydrated. Facility staff would like the patient evaluated at St. Luke's ED for this condition. Here is the history of the present illness. The patient states that she vomited once about an hour ago and once after breakfast, approximately 3 hours ago. The facility staff confirms the frequency of vomiting and states that the episodes were brief and only contained a small amount of emesis. The assessment of our patient. On assessment, airway, breathing, skin color, temperature, and moisture are normal. No obvious injuries or bleeding. Patient has a strong radial pulse and lung sounds are clear. Patient denies any abdominal pain at this time. Abdomen is soft, non-distended, negative rebound tenderness or guarding present. No pulsatile mass or trauma noted. Patient denies blood in emesis or stool. Here's the portion of the narrative that documents our treatment. At this time, the patient requires no further interventions from EMS. Patient condition and vitals were monitored during transport without change. The patient was given an emesis bag in the event she felt the need to vomit. Here is the transport of our patient. The patient was transferred to the EMS cot using a draw sheet and slide board using 2 personnel. The patient was secured to the cot with all straps. The patient was moved to the ambulance via stretcher and was transported to St. Luke's ED as requested by facility staff for evaluation of acute onset vomiting and possible dehydration. Here's the reevaluation of our patient during transport. The patient's vitals were reassessed as well as overall condition remained unchanged during transport. There were no episodes of vomiting during transport. Lastly, here is the final disposition of our patient. On arrival at St. Luke's ED, the patient was taken to room 8. Demographic information was shared with hospital registration. A report was given to the EDRN without any questions. No additional patient belongings were transferred with the patient. A current medication list was left with the EDRN, and Unit 356 returned to service.